If we Vertical control is important for treatment outcome. We want to know what to do with lower facial height. Should we maintain it or change it? If we have maxillary or mandibular excess, we need to address it. It is not the same to treat high or low angle case class 2 cases. Class 2 hypodivergent patient is more likely to need orthodontic surgery, as the two characteristics, vertical and sagittal, are more pronounced, as certain is the necessity for surgery. Also, vertical dimension is going to affect aesthetics. Think of gingival display. Functional guidance can be affected by the curve of Spee. And yes, changes in vertical dimension are affecting sagittal dimension too. In class 2 patient, if we perform impaction of maxilla with orthodontic means or surgical means, mandible is going to auto-rotate counterclockwise and its sagittal projection is going to enhance sagittal relationship, transforming a class 2 into a class 1. By raising lower facial height, mandible is rotated clockwise. Its sagittal projection is changed and class 2 worsens. How do we control vertical dimension? We can use arch wires, continuous or segmented. We can use anterior or posterior bite razors. We can use TADs or TAD anchor devices. We could use headgear with high or low pull, and of course we can use orthodontic surgery. For example, this is a class 2 division 2 patient with slight asymmetry of the mandible. She has straight smile line and strong masseter muscle. Extrusion of posterior teeth tend to relapse in these patients. She has class 2 half cusp. She has tooth wear, vertical steps, accentuated curve of Spee. Our plan was to intrude upper and lower incisors and to procline them, and to extrude a little bit the posterior teeth. And of course, the correction of class 2. She is a low angle case with retroclined upper and lower incisors. I applied my bracket system, and in the upper jaw I overlaid a utility arch. I used continuous arch wire in lower arch in order to level the curve of Spee with some extrusion of premolars. Later, I added utility in the lower jaw too. Utility arch produces intrusion but also some proclination of anterior teeth, all desired movements in this case. At the end of the treatment, we have a good facial aesthetics and a relatively good exposure of teeth in smile and rest position. And, of course, we achieved class 1 occlusion. For vertical control in frontal area, you can use utility 2x2 or 2x4. This arch is going to do intrusion and proclination of the incisor and some extrusion of molars. Be careful on applied forces. For intrusion, low forces are recommended, and the moment created by low force in molars is not going to tip them. If high forces are used, molar tipping is inevitable. If you want to do in the same time intrusion and retraction of the frontal segment, you can use utility retraction arch. If segmented arch wires are a challenge, there are always TADs and TAD-borne appliances that can be used for vertical control. TADs are easy to use and they have great value in vertical control. Sometimes we have other problems besides vertical, and the appliances used to solve these problems can be used for intrusion too. In image you can observe an MSC2 with vertical elastomeric chain to the buttons on the molars. PSM benefit system mousetrap that you can see in the lower left corner is another device used for vertical control. Gauge-Gerion arch can be used for vertical control too. If it has some distance from palatal vault, the tongue will press on it and it will have intrusion effect. I'm going to speak more on bone-borne appliances in Rome, so meet you there. Extraoral forces are efficient in vertical control, but the compliance can be an issue. With the high pull headgear, we can do some distalization and intrusion, and with the low pull headgear, we can obtain some extrusion of the posterior area and change in the occlusal plane. Bite razors can help us controlling vertical dimension. They can be made in molds with composite for band cementation, or they can be ready-made from different materials and you need to bond them to the teeth surface. Making a bite razor on molars is a child's play. You just need to apply some composite. Do not apply bite turbos when posterior extrusion is unwanted. For hypodivergent cases, I recommend bite blocks on posterior teeth. Bite razors can be used for sagittal control also, and we will discuss that in the next part.